Welcome to the deep dive. Today we're jumping into something really key for nursing students: pediatric renal dysfunction.
It's a really important area, foundational, I'd say.
Definitely. We're using Wong's Nursing Care of Infants and Children as our main source today, kind of our guide for this deep dive. Our aim is to really unpack kidney issues in kids, go beyond just, listing things.
Looking at everything from common infections to the more complex structural and functional problems.
Exactly. And to help us really grasp some of the maybe more challenging ideas, we have our renal expert joining us.
Glad to be here. Hopefully I can help clarify some things.
Fantastic. Okay, let's start with the basics. The renal system itself, what it does. Our source reminds us it's not just about waste, right?
Oh, far from it. Kidneys are workhorses. They manage fluid and electrolyte balance, acid-base levels, blood pressure.
And even red blood cell production, erythropoietin.
Precisely. And then waste excretion. So, yeah, when kidney function is off, it affects a lot.
And these problems in kids, they can start in different ways.
Right. Some are congenital there from birth. Others are acquired later, maybe from infections or other causes. Nursing students need to keep that range in mind.
Which leads us straight to assessment. How do, as nurses, pick up on potential renal issues early on? What's key in the history?
History is crucial. You absolutely need to ask about voiding patterns, how often, any pain, volume changes.
Yeah.
History of UTIs is a big one. Any previous infections. Also ask about swelling edema, especially around the eyes or feet. And growth, are there any concerns there? Renal issues can impact growth.
And then the physical exam, what are we looking for?
Well, you'll want to gently palpate the abdomen. Sometimes you can feel masses or enlarged kidneys.
Right.
Blood pressure is non-negotiable. Got to get an accurate reading. Kidneys and blood pressure are tightly linked.
Right.
And observe closely for that edema we mentioned, or signs of dehydration too. The kidneys regulate fluid, so problems can go either way.
Let's talk labs. The source mentions BUN, creatinine, urinalysis. How should students think about these? What's the story they tell?
Good question. Think of BUN and creatinine as markers of filtering efficiency. If they're up, it usually means the kidneys aren't clearing waste effectively.
Okay, filtering efficiency. Got it.
Urinalysis is like looking directly at what the kidney is putting out. Proteinuria protein in the urine is a big red flag. Healthy kidneys hold on to protein.
What about things like leukocytes or nitrites?
Those often point toward infection, a UTI. Blood in the urine, hematuria, is another significant finding. And specific gravity tells you about the kidney's ability to concentrate urine.
And electrolytes, pH.
Yeah, those tell us about the kidney's role in maintaining the body's overall chemical balance. Super important functions.
And if we need to actually see the structures, imaging.
Ultrasound is usually the first port of call. It's non-invasive, no radiation, gives a good look at kidney size, structure, any blockages.
Makes sense.
Then there's the VCUG voiding cystourethrogram. That's key for looking for reflux, urine flowing the wrong way. We use contrast eye for that one.
We'll definitely come back to reflux. Any others?
Renal scans can show how well each kidney is functioning individually. And sometimes, though less often, a CT scan might be needed for really detailed anatomy.
Okay, great overview. Let's dive into one of the most common issues nurses will see: UTIs, urinary tract infections.
Oh, absolutely. You'll encounter these frequently.
The source highlights they're especially common in girls and uncircumcised boys under a year old. Why that specific group?
Well, for girls, it's largely anatomy. The urethra is shorter, making it easier for bacteria, usually from the bowel, to get into the bladder.
Simple proximity.
Exactly. And in uncircumcised boys, particularly infants, bacteria can sometimes colonize into the foreskin, increasing the risk.
And the main culprit bacteria is usually E. coli.
That's right. E. coli, normally found in the gut, is far and away the most common cause.
So what are the telltale signs in kids? I imagine they don't always say, "It hurts when I pee."
No, especially not the little ones. In infants and toddlers, the signs can be really nonspecific. Unexplained fever is a big one. Irritability, poor feeding, maybe vomiting, or just, urine that smells unusually strong or foul.
Tricky.
Very. Older children might give you more classic signs. Dysuria, that's painful urination needing to go urgently or frequently, abdominal pain, and that foul-smelling urine again. Sometimes a child who is toilet trained might start having accidents. That can be a sign too.
So if we suspect a UTI, how do we confirm it?
The definitive diagnosis comes from a urine culture and sensitivity test. You need a properly collected urine sample for that.
Culture and sensitivity.
Right. The culture identifies the specific bacteria causing the infection. The sensitivity part tells us which antibiotics will be effective against that particular bug.
Critical for choosing the right treatment. So what is the nursing role in managing a UTI once it's confirmed?
Treatment revolves around antibiotics. Depending on the severity and the child's age, it might be oral antibiotics.
Like which ones typically?
Common ones include trimethoprim sulfamethoxazole or perhaps amoxicillin clavulanate. But if the infection is severe or the child can't take oral meds, they might need IV antibiotics in the hospital, something like ceftriaxone or cefazolin maybe.
Okay.
Nurses play a huge role in encouraging fluid intake. Really push those fluids to help flush the bacteria out.
Makes sense.
And education is paramount. Teaching families about proper hygiene wiping front to back for girls is key for prevention. Also, ensuring kids void regularly and completely empty their bladder.
Good preventative stuff. Okay, let's shift to structural issues. Vesicoreteral reflux, VUR, is mentioned first. What exactly is happening there?
Okay, VUR. Think of the tubes connecting the kidneys to the bladder, the ureters. Normally where they enter the bladder, there's a sort of one-way valve mechanism.
Sense backflow.
Exactly. In VUR, that valve doesn't work properly, so urine from the bladder can flow backwards, retrograde, up the ureters, sometimes all the way back to the kidneys.
And why is that backflow a problem?
The big danger is kidney infection, pyelonephritis.
Well.
If there's bacteria in the bladder urine, reflux pushes it up into the kidneys. Repeated infections can lead to kidney scarring, and that scarring can cause long-term damage, high blood pressure, even reduced kidney function down the line. So catching VUR is important.
We mentioned the VCUG test diagnoses it. What's that like for the child and family nursing role?
Right, a VCUG. A small catheter is put into the bladder, and contrast dye is instilled. Then, using live X-ray fluoroscopy, we watch as the bladder fills and as the child voids. We're looking to see if dye goes back up the ureters.
Sounds a bit intimidating for a kid.
It can be. So the nursing role involves preparing them, explaining what will happen in age-appropriate terms, providing support during the procedure, maybe distraction techniques. Afterwards, we monitor for any discomfort or signs of infection from the catheterization.
How is VUR usually managed then? Does it always need fixing?
Not always. It depends on the grade, the severity. Lower grades might resolve on their own as the child grows and that valve matures.
So observation sometimes.
Yes. Sometimes watchful waiting with regular checks. Often, though, kids are put on a low daily dose of antibiotics, prophylactic antibiotics to prevent UTIs, while the reflux hopefully resolves. Trimethoprim sulfamethoxazole or nitrofurantoin are common choices for prophylaxis.
And if that doesn't work or it's severe?
Then surgery might be needed. There are procedures to reimplant the ureters into the bladder in a way that creates a better valve, preventing the reflux.
Okay, let's move to another structural issue. Obstructive uropathy. What does that term cover?
Obstructive uropathy basically means there's a blockage somewhere in the urinary tract that impedes the normal flow of urine.
Like what kind of blockages?
Common examples in kids include posterior urethral valves, which are little flaps of tissue in the urethra of boys that block outflow from the bladder, or a ureteropelvic junction obstruction, a blockage where the ureter meets the kidney pelvis, or even a ureterovesical junction obstruction, where the ureter meets the bladder.
And the consequence of these blockages? If urine can't get out,
it backs up. This leads to dilation or swelling of the parts upstream from the blockage. If it backs up into the kidney, that's called hydronephrosis swelling of the kidney.
And that pressure can damage the kidney.
Absolutely. Prolonged pressure from backed up urine can damage kidney tissue and impair function over time. That's why relieving the obstruction is crucial.
So treatment is usually surgical. What's the nursing focus?
Yes, the primary treatment is almost always surgery to correct the blockage and allow urine to flow freely. Post-op nursing care is key. Monitoring urine output very closely, managing pain, preventing infection at the surgical site. Sometimes temporary drains or tubes, like nephrostomy tubes, might be placed, and nurses manage those and teach families care.
Got it. Now, bladder exstrophy sounds very serious. What is that?
It is a serious, complex congenital defect. Basically, the bladder develops incorrectly and is open and exposed on the outside of the abdominal wall. It's essentially turned inside out. Often occurs with related issues with pelvic bones and genitalia.
Wow. What are the priorities for nursing care there?
Immediately after birth, the absolute priority is protecting that exposed bladder mucosa. Keep it moist, covered with sterile, non-adherent dressing, prevent infection, meticulous skin care around it. Long-term, it requires multiple complex surgeries to close the bladder, reconstruct the urinary tract, and address other anomalies.
Intensive care done.
Very intensive post-op care. Wound management, pain control, high risk of infection needs constant vigilance. managing urinary diversions if they're needed, and huge emotional support for the family coping with such a visible and challenging condition.
And briefly, hypospadias and epispadias.
These relate to the position of the urethral opening on the penis. Hypospadias means the opening is on the underside, somewhere along the shaft instead of at the tip. Epispadias, which is rarer, means the opening is on the upper side.
How are these corrected?
Both require surgical correction. The goal is to reposition the urethral opening to the tip of the penis for normal urination and later normal sexual function. Surgery is usually done in infancy or early childhood, typically before toilet training age. Post-op care involves managing pain, maybe a temporary catheter or stent, and careful wound care education for parents.
Okay, shifting from structure to function, let's talk nephrotic syndrome. Key features.
Nephrotic syndrome is a kidney disorder characterized by a specific group of signs. The big one is massive proteinuria, losing large amounts of protein, especially albumin, in the urine.
Okay, massive protein loss. What does that lead to?
That loss of albumin from the blood leads to low albumin levels, hypoalbuminemia. Since albumin helps hold fluid in the blood vessels, when it's low, fluid leaks out into the tissues, causing generalized edema swelling.
Ah, the edema connection.
Right. And the liver tries to compensate for low albumin by making more fats, leading to hyperlipidemia, high cholesterol, and triglycerides. So the tetrad is massive proteinuria, hypoalbuminemia, edema, and hyperlipidemia.
What should nurses be looking for in a child presenting with this?
The edema is usually the most obvious sign. Often starts around the eyes, periorbital edema, worse in the morning, then swelling in the legs, abdomen slights, maybe genitals. Significant weight gain from all that fluid. Urine might look frothy or foamy because of the high protein content. Urine output might decrease.
So key nursing assessments are daily weights, strict INO.
Absolutely. Daily weights are critical, strict intake and output. Measuring abdominal girth can track ascites. Assessing for skin breakdown because of the edema is important too. Monitoring blood pressure, it can be normal or sometimes elevated.
The source mentions minimal change nephrotic syndrome, MCNS. Is that common?
Yes, MCNS is the most common type of nephrotic syndrome in young children, typically toddlers and preschoolers. It's called minimal change because the kidney filters, the glomeruli, look mostly normal under a standard microscope, even though they're leaking protein.
And the good news about MCNS?
The good news is that it usually responds really well to treatment with corticosteroids.
Okay, so treatment often involves steroids. What's the nursing role there?
Corticosteroids, like prednisone, are the first line of treatment, usually started at a high dose and then slowly tapered over weeks or months. Nurses administer the medication, but crucially, educate the family about it.
Side effects.
Yes, potential side effects like increased appetite, weight gain, mood changes, increased susceptibility to infection. Managing severe edema might require diuretics like furosemide, so we monitor electrolytes carefully. Sometimes IV albumin infusions are given if levels are very low. Preventing infection is vital because steroids suppress the immune system.
And follow-up.
Essential. Relapses are common. Families often learn to check urine for protein at home using dipsticks to catch relapses early.
Okay, next up, acute glomerulonephritis, AGN, often follows a strep infection.
That's the classic type, acute post-streptococcal glomerulonephritis, or APSGN. It's an immune reaction. About 1 to 3 weeks after a strep throat or skin infection, immune complexes, antibody-antigen clumps, get trapped in the glomeruli.
Causing inflammation.
Exactly. Inflammation and damage to the glomeruli, which reduces their filtering ability.
What are the hallmark signs nurses should watch for with AGN?
Think head strep. H for hypertension. A for ASO titer positive, a test for recent strep. D for decreased GFR, glomerular filtration rate, so decreased urine output, oliguria. S for swelling, edema, often periorbital again. T for T-colored urine, which is hematuria. R for recent strep infection. E for elevated BUN and creatinine. P for proteinuria, though usually milder than in nephrotic syndrome.
That's a helpful mnemonic. Had strep. So management.
Management is mostly supportive because it often resolves on its own, focuses on managing the symptoms. Sodium and fluid restriction are key to control the edema and hypertension.
Medications.
Antihypertensives are often needed drugs like labetalol or nifedipine might be used. Diuretics, like furosemide, can help with fluid overload, but the mainstay is careful monitoring.
Monitoring what specifically?
Vital signs, especially blood pressure very closely. Strict intake and output, daily weights to track fluid balance. Monitoring renal function labs like BUN and creatinine, basically supporting the child while the kidneys recover.
Okay, let's talk about hemolytic uremic syndrome, HUS. It has a distinct triad, right?
Yes, the classic triad defines HUS. First, Hemolytic anemia, red blood cells are destroyed prematurely. Second, thrombocytopenia, low platelet count. And third, acute renal failure or acute kidney injury.
And there's often a link to a specific E. coli strain.
Very strong link, especially to E. coli 0157 BOD-H7. This strain produces a toxin, Shiga toxin, which damages the lining of small blood vessels, particularly in the kidneys. It's often contracted from contaminated food, like undercooked beef or unpasteurized products.
What's the typical presentation? What might the child have experienced first?
Usually there's a preceding illness, often severe gastroenteritis with vomiting and classically bloody diarrhea. Then, a few days later, the child starts showing signs of the triad. Pallor from the anemia, maybe bruising or petechiae from the low platelets, and decreased urine output, oliguria, signaling the kidney injury.
Sounds very serious. Nursing care priorities.
It is very serious. Treatment is entirely supported. There's no specific cure for the toxin's effects. Care focuses on managing the complications. Dialysis is often required to support the failing kidneys.
Transfusions.
Possibly. Red blood cell transfusions for severe anemia, maybe platelet transfusions if there's significant bleeding, but these are given cautiously. Fluid and electrolyte management is incredibly critical and complex. We monitor neurological status closely too, as the toxin can affect the brain. Basically, intensive supportive care until the body recovers.
Which brings us to renal failure itself. Let's start with acute kidney injury, AKI. How is it defined? Causes.
AKI is a sudden rapid loss of kidney function. It leads to waste buildup, fluid and electrolyte imbalances. It's often defined by a sharp rise in serum creatinine or a significant drop in urine output. Causes in kids are varied. It can be prerenal, like severe dehydration reducing blood flow to the kidneys. Intrinsic, meaning damage within the kidney itself, like from toxins, severe infections, or conditions like HUS or AGN. Or postrenal, caused by an obstruction blocking urine outflow.
What are the core nursing actions for AKI?
Monitor, monitor, monitor. Especially urine output. Is it low, oliguria, or absenteria? Watch for signs of fluid overload, edema, crackles in the lungs, hypertension. Track labs closely. BUN, creatinine, electrolytes, especially potassium, which can get dangerously high.
Interventions.
Focus on treating the underlying cause if possible.
Yeah.
Strict fluid management is key, often fluid restriction. We need to correct electrolyte imbalances urgently, particularly hyperkalemia. Medications like sodium bicarbonate or calcium gluconate might be used for that. And if kidney function is severely impaired, dialysis becomes necessary.
Then there's chronic kidney disease, CKD. This is different, progressive, irreversible.
Exactly. CKD is a gradual loss of kidney function over time, typically months or years. It's progressive, and unlike AKI, the damage is generally irreversible.
What kinds of things lead to CKD in children?
It can be congenital abnormalities. They're born with kidneys that didn't form properly, hypoplasia, dysplasia, inherited diseases like polycystic kidney disease, or acquired conditions like chronic glomerulonephritis, or damage from long-standing VUR, reflux nephropathy. Even systemic diseases like lupus can cause CKD.
Managing CKD in kids must be complex, given all the kidney's roles.
Extremely complex. As function declines, you see widespread effects. Growth failure is common today. Kidneys play a role in growth hormone activity. Anemia develops because kidneys make erythropoietin.
Right.
Metabolic acidosis occurs because they can't handle acid waste. Bone disease, renal osteodystrophy happens due to problems with calcium, phosphorus, and vitamin D metabolism. Hypertension is almost universal.
So management involves tackling all of these.
Yes, it's a multidisciplinary effort. Dietary restrictions are crucial, limiting sodium, potassium, phosphorus. Medications are used to manage complications. Growth hormone injections, erythropoietin-stimulating agents like epoetin alpha for anemia, bicarbonate to correct acidosis, phosphate binders like calcium carbonate or sevelamer with meals. Blood pressure control is vital.
And eventually,
As CKD progresses to end-stage renal disease, ESRD, the options become dialysis or kidney transplantation.
let's touch on dialysis in kids. Peritoneal dialysis first.
Peritoneal dialysis, or PD, uses the child's own peritoneal membrane lining the abdomen as the filter. A soft catheter is surgically placed in the abdomen. Dialysis fluid is instilled, dwells for a time to pull out waste and fluid, then drain.
Advantages, risks.
A big advantage is it can often be done at home, usually overnight, which allows for more freedom during the day. It's generally gentler than hemodialysis. The main risk, and it's significant, is peritonitis infection inside the abdomen. Meticulous sterile technique during exchanges is critical.
And hemodialysis.
Hemodialysis, or HD, uses an artificial kidney machine. Blood is pumped from the child's body through the dialyzer machine, which filters it, and then returned to the body. This requires reliable vascular access, usually an AV fistula or graft created surgically in the arm, or sometimes a central venous catheter.
Schedule. Nursing care.
HD is typically done in a dialysis center, usually 3 times a week for several hours each session. Nursing care involves connecting the child to the machine, monitoring them very closely during the treatment, vital signs, blood flow, clotting issues. Assessing and protecting the vascular access is crucial. Managing fluid shifts, it's quite demanding.
Finally, kidney transplantation, the preferred option for ESRD.
Generally, yes.
Yep.
Transplantation offers the best chance for a more normal life, better growth, development, and quality of life compared to long-term dialysis.
But it comes with its own challenges, lifelong medication.
Absolutely. The biggest is the need for lifelong immunosuppression medication to prevent the body from rejecting the new kidney. Drugs like tacrolimus, cyclosporine, mycophenolate, prednisone, these have side effects and require strict adherence.
What's key for nursing care post-transplant?
Infection prevention is huge because the immune system is suppressed. Educating the child and family about the complex medication regimen, what each drug does, when to take it, potential side effects, the critical importance of never missing doses. Monitoring for signs of rejection fever, tenderness over the kidney, decreased urine output, rising creatinine, providing ongoing support. It's a lifelong commitment.
Okay, stepping back, across all these conditions, what are the universal nursing principles?
Some things are constant. Meticulous monitoring, daily weights, strict intake and output, blood pressure trends, watching electrolyte levels, preventing complications. Infection control is always key. Managing fluid balance carefully to avoid overload or dehydration, preventing skin breakdown, especially if there's edema.
And the family.
Crucial. Providing clear education about the condition, treatments, medications, dietary or fluid restrictions. Offering emotional support. These conditions impact the whole family, and they need resources and understanding to cope long-term. Empowering them to manage care at home is a major nursing goal.
This has been incredibly thorough. We've covered so much ground, drawing from Wong's text, and your insights have really helped illuminate the complexities of pediatric renal care. It underscores just how vital this knowledge is for nursing students.
It really is. Being able to recognize the subtle signs, understand what's happening physiologically, and intervene appropriately, it makes a world of difference for these kids and their families. It's challenging but very rewarding work.
Absolutely. So for all of you listening and learning, here's something to think about. How does truly understanding the renal system's intricacies, the physiology, the potential dysfunctions, the treatments shape not just your immediate actions as a nurse, but the entire long-term health journey and quality of life for your pediatric patients and their families? Keep digging into your resources, keep asking questions. This knowledge is powerful. Thanks for joining us on the deep dive.